So here you are watching coblation adenoidectomy in a 6-year-old child with obstructive symptoms and some ear-related recurrent issues. You can see the adenoids are almost grade 3. The You can see the palate is being pulled with the soft rubber catheter. This video is being recorded on 20th March 2025. So you start with coblation at the setting of 9 for ablation and 3 for coagulation, 3 or 4. I have already done intracapsular tonsillectomy for this child, and I'm starting with the upper pole of the adenoid, which is the buccopharyngeal fascia, which is the periosteum below the sphenoid bone. And we're doing a complete clearance from the superior pole. Now this is the eustachian tube, so I'll make sure that we do not damage the eustachian tube orifice and remain 4 to 5 millimeter away from that. And now layer by layer we'll debulk the lymphoid tissues. We will make sure that this child does not require any grome or any ear-related issue, because if you do not remove the adenoids completely and try to treat the child's uh, serous otitis media by putting a grome, that's an unnatural way of dealing with things, because the problem has started because of the eustachian tube blockage due to adenoids. So the most logical solution is to deal with the root cause of the problem rather than dealing with the effect. So now that's the superior boundary of the adenoids completely defined, which is the buccopharyngeal fascia. Which is the periosteum below the sphenoid bone. Now this is the eustachian tube orifice. The lateral boundary of the adenoid is the anteriorly it is the torus tuberous. This is the torus tuberous, and you can see a lot of lymphoid tissues on the torus tuberous, which I am removing, remaining 4 to 5 millimeter away from the eustachian tube orifice. Can you see this? So that there is no scarring of the orifice, but all this lymphoid tissue submucosally I am removing completely, so that we can give the chance for the best healing of the chronic ear issues that the child has without cutting open the eardrum. And now you can see this is the, you do not have to open up the muscle. See, this is submucosal. I have not opened the muscle, I have not exposed the muscles also. That is the lateral boundary anteriorly, right? I have remained away from the eustachian tube. And now I am going for the fossa of Rosenmuller, which is the lateral boundary posteriorly. So these boundaries were defined first time by our paper in 2016. And this video is getting recorded today in 2025, almost 9 years later, because still many people feel that adenoidectomy is an unnecessary surgery, it should not be done. Problem is that if you do not tackle it in time, then you have to tackle the chronic ear issues later in the adulthood. This is the depth. Let me debulk the adenoids to reach the posterior boundary, which is the buccopharyngeal fascia, which I'll reach in a moment. So laterally, you have to be a little more careful. Now see how much of depth is still there. That's the whole point. That when you do a blind curate adenoidectomy, you leave a lot of tissues here and there. Now you can always argue that it's not malignancy, so how does it matter whether you leave or not? Then you have subjected the patient to anesthesia. You are doing a surgical procedure. Why not do it completely? And why not do it cleanly? So that's the buccopharyngeal fascia, which is the posterior boundary. Alright, now the inferior boundary will be the passavant's ridge. You can already see that the adenoids are ending over here. The boundaries of adenoids is a published paper in March 2016 issue of the Indian Journal. Those who are interested can go through it. Now, this is the passavant's ridge area. Still, there is a lot of adenoid tissue. That's the fossa of Rosenmuller, which is completely cleared. And let me go down to the. Now, this wand is almost over. You can see that it has stopped working. So, after performing intracapsular tonsillectomy left and right, and after doing one side of the adenoid, the wand is over. I will need to change the wand for the second side. So now, cost and all those things are a different consideration. Cost can be very important for somebody. Cost may not be a factor at all for the other person. Important is what scientifically what is achieved by which tool. That is the question. And what you will do in a certain case will again depend on a lot of factors, but scientifically, can you conclusively achieve this kind of clearance with another tool? And obviously, with this tool also, you require a lot of experience. My hands are not as good as they are today, and obviously, they'll still keep on becoming better and better. This is 25 years of ENT practice now, and almost 18 years of, uh, 17 years of using coblation. So this is the right side. Now my wand is almost over. I'll come to the left side. Thank you for watching the right side and the mouth.